Good morning, everyone. I'm Dr. Gitika, and I'm an assistant professor in Department of Obs and Gynae in SGT Medical College. Today, we'll be studying about face and brow presentation. So, let's go through the video. As we can see that in the normal lie of the baby inside the uterus is longitudinal lie and the presentation is cephalic, and the attitude of the baby is that of flexion. That means that there is flexion at all the joints, at the knee, at the hip, at the elbow, shoulders, and the neck. So this makes a well-flexed head makes the denominator to be the occiput. But there are certain malpresentations which can occur because of some known and some unknown reasons. So what happens in face presentation? In face presentation, the fetal head and the neck are hyperextended, causing the occiput to come in contact with the upper back of the fetus while lying in a longitudinal axis. So the fetus is lying in the longitudinal axis, but the head and the neck, they are hyperextended. The presenting portion of the fetus is the fetus face between the orbital ridges and the chin. So the presenting portion becomes the face. So these are some of the diameters which are very important and we all should know it. So if the presentation is vortex, the attitude is that of complete flexion. So here the presentation is vortex and the attitude, you can see the neck is flexed, and this makes the engaging diameter suboccipito-bregmatic, which is 9.5, and the denominator is the occiput here. The other presentation is occipito-posterior presentation, in which there is partial deflection of the fetal leg, and the engaging diameter here becomes occipito-frontal diameter, that is, it is from the occipital bone to the frontal, and it is between 11 to 12 centimeters. Then is the brow presentation, when there is partial extension of the neck. You can see here that here the attitude is that of flexion at the neck. Then this is incomplete flexion. This is the deflexed head. We call it as a deflexed head. And this is partial extension. When there is partial extension, the presenting diameter is mento-vertical. And this presentation is known as the brow presentation because here the presenting part is the brow. The the mento-vertical diameter here is 13.5 to 14 centimeter, and normal mechanism of labor is not possible in this presentation. So if there is a persistent brow presentation, we have to take the patient for cesarean section. Now at the last, when there is complete extension of the fetal neck, this makes the denominator, the presenting part as the face, and the engaging diameter is submento-bregmatic. So this is the bregma and this is the submental region, and it is again 9.5. And the denominator here is the mentum. So we will study this presentation today. That is the face presentation, where the baby presenting part is the face, the engaging diameter is submento-vertical, and the axis in which the baby lies inside the uterus is the longitudinal lie, and here the denominator is the mentum. So this is again the revision of the same diameter which I have just told. So we can see how the baby comes out in face presentation. So this is the baby. The attitude at the neck is that of complete extension. So the engaging diameter is submento-bregmatic. So this is the bregma. This anterior fontanelle is known as the bregma, and the area just below the mentum is the submental area, and the engaging diameter is the submento-bregmatic diameter, which is 9.5, and the attitude is that of complete extension at the fetal neck. The rest of the joints can be in a flexed position, but the neck is at complete extension and the lie of the baby is longitudinal, and the denominator is the mentum. This is the denominator. So this is another picture which is showing the baby coming as a phase presentation. So the key parameters, just to revise it quickly: attitude is complete extension at the neck. Engaging diameter is submentobrygmatic. And the denominator is mentum. So what do you mean by denominator? Denominator is a bony fixed point on the presentation which comes in relationship to the various quadrants of the maternal pelvis. So we take the mentum as the denominator and we tell the position of the fetal head with respect to the maternal pelvis. So if the mentum is anterior and it's on the right side, then the position becomes right mento-anterior. Likewise, the position can be left mento-anterior, right mento-posterior, or left mento-posterior. So these are the various positions which we are showing in this diagram with respect to the mentum in relation to the maternal pelvis. So here we can see that the mentum is on the right side and it is anterior. So this position is right mento-anterior. Then this is left mento-anterior. Now in these two diagrams, the mentum is posteriorly placed. So here the position is right mento-posterior and here the position is left mento-posterior. Hope this is clear. So just remember one thing, that the denominator is the mentum, attitude is that of complete extension at the fetal neck, and the engaging diameter is submentobrygmatic diameter, and the denominator is the mentum. So these things, they are very important from exam point of view. Now talking about the etiology, why does the phase presentation occur? So it can be because of various reasons. Primary phase presentation is rare and it mostly occurs during the pregnancy. It is usually caused due to some fetal factors or maternal factors. So to name a few, there is a condition known as anencephaly where there is absence of bony vault of the skull and the scalp while the facial portion is normal. So in this condition, mostly the baby is lying in phase presentation. We have, if there are number of loops around the baby neck, this can lead to extension of the neck and the face becomes the presenting part. So loops of cord around the neck. If there is any tumor in front of the fetal neck, then the flexion won't be possible in that case and the fetal head will remain in extension. So it can be the cause of phase presentation, for example, the congenital goiter. So anything which is obstructing the flexion of the baby's neck, it can lead to phase presentation. Next is hypertonicity of the extensor group of the muscles of the neck. So these are the extensor groups, this is the flexor group. So if these group of muscles, they are hypertonic, they are contracted, so the baby's face will be extended and it can't be flexed. So this is one of the reasons. Then there is dolichocephaly, that is the long anterior posterior diameter of the head can also lead to phase presentation. If the baby is dead, the baby is premature, it can also be a cause of phase presentation. And the last one is idiopathic, when we don't know the cause. So this is a very beautiful picture you can see of anencephaly. We can see that the vault is absent over here, and also the portion of, sometimes the portion of the baby's brain is also absent, and this makes the face as the presenting part. So anencephaly being one of the causes of face presentation. Now talking about mechanism of labor. How does the baby is born in phase presentation? Firstly, we know the cardinal movements of normal mechanism of labor. So the cardinal movements of normal mechanism of labor includes engagement, then the descent, which is a continuous process, then there is friction, then there is internal rotation, then there is delivery of the head by extension, and then there is restitution, and then there is external rotation and delivery of the body by lateral flexion. So here, in phase presentation, there are certain minor changes which we should know about. So here the engaging diameter is submentobrachmatic diameter, and it engages in left or right oblique diameter. The vertical diameter between the face and the biparietal diameter is more than the vertical diameter between the pelvic brim and the ischial spine. So the engagement is a bit delayed in phase presentation. So just you have to remember that the vertical diameter between the, this portion has to engage, and the vertical diameter between the biparietal and between the face is more than the vertical diameter between the pelvic brim and the ischial spine. So that's why the engagement is delayed in phase presentation. So the next point in the next slide, we will talk about the descent. We all know that in labor, the descent of the baby is a continuous process. So the descent is a continuous process. With the descent in phase presentation, there will be increasing extension. So you can just compare it from normal labor. In normal labor, when the head is in that of flexion, there is increasing flexion of the fetal head. Now, but in phase presentation, there is increasing extension of the fetal head as the trunk descends, and this extension of the fetal head, it increases. Then there is internal rotation. So there will be increasing extension. The head is coming like this. When this mentum will touch the pelvic floor, it rotates by 1/8 of a circle, bringing this mentum under the pubic symphysis. Hope this is clear to you. So this is the mento-anterior position. So this is, they are showing the left mento-anterior, and so once the mentum, it touches the pelvic floor, this mentum will rotate by 1/8 of a circle. So this is the full circle, okay? And we are dividing this circle into 8 quadrants. So when this mentum will touch the pelvic floor, this mentum will rotate, and it will come beneath the pubic symphysis. So they are showing in this. So the mentum has come beneath the pubic symphysis. So this rotation inside the maternal pelvis is the internal rotation. Then this chin, it hitches under the pubic symphysis. So when the baby is coming like this, mento-anterior position, the chin will hinge under the pubic symphysis, and the head will be born by flexion. So what are the things which can be born successively? The mouth, the nose, the glabella. This is the glabella. This is the forehead. The vertex, the occiput are born in this order. So the head will be born like this. So this is again different from normal labor. In normal labor, the head is delivered by extension. The head comes like this. Whereas in phase presentation, the head delivers by flexion. So these 2 points are different in normal labor and in phase presentation. In normal labor, there is increasing flexion of the fetal head when there is descent. Whereas in phase presentation, there is increasing extension of the fetal head. The head in normal labor is born by extension. There will be increasing flexion, then there will be extension in normal labor. Here in phase presentation, there will be increasing flexion, increasing extension, and then there will be flexion and delivery of the fetal head. Hope I'm making myself clear. After the head is born by flexion, then there is a movement of restitution. that is the fetal head, it aligns with the fetal shoulder. And this rotation is in the direction opposite to that of internal rotation, so that the twisting of the neck can be unturned. And then there is external rotation, which occurs because of the internal rotation of the fetal shoulders. So this external rotation is because of the internal rotation of the fetal shoulders. There are certain complications. Why we want to know about face presentation? How are we bothered about it? How is the baby coming? Because in face presentation, there are certain complications which can arise. So these can be broadly divided into maternal and fetal complications. If we talk about the maternal complications, we have pre-labor rupture of membranes, because why do the membranes rupture early in face presentation? Because the proper ball valve phenomena, when there is well flexed head, the vortex, it fits into the dilating cervical canal, and the membranes, they don't rupture early. Whereas when the face is coming, so the cervix is like this, the proper ball valve phenomena is lost here. So this can lead to pre-labor rupture of membranes. And since there is loss of ball valve phenomena, just imagine this is the cervix and the fetal head is coming like this. So this space is empty, this space is empty. So the proper ball valve phenomena is lost here. So when the membranes rupture, even the cord can prolapse. So the second complication is the cord prolapse, and it is an obstetric emergency. The baby has to be delivered as soon as possible. There can be prolonged labor. There are more chances of operative vaginal delivery, and there can be cesarean section. I'm sorry for some of the spelling mistake here. And in fetal, there can be congenital anomalies. As I have told you that anencephaly is one of the conditions which is associated with face presentation. There can be fetal heart rate abnormalities. There can be facial edema because the face is coming down. So the venous return and the lymphatic drainage is obscured. So that's why there can be edema at the face. There can be laryngeal edema, tracheal edema, and the baby may require NICU admission. So just this, I've just made another slide telling the complications, and they are almost the same. They can be prolonged labor, they can be facial trauma, they can be facial edema, they can be skull molding, respiratory distress, spinal cord injury, abnormal fetal heart rate pattern, and the low APGAR score. So this is just a picture. The baby was delivered by face presentation. It's taken, I've just taken it from it. So you can see this is the bruising of the, and there is the edema of the one of the eyelid. So these are some of the complications, common complications which we encountered in face presentation. Now talking about how do we diagnose face presentation. So face presentation is diagnosed either in late first stage or in second stage of labor. We can't diagnose it in the early stages of labor, because mostly we need to do upper vaginal examination to diagnose this. So the distinctive facial features like chin, mouth, nose, cheekbones can be felt. So once we are doing upper vaginal examination for the lady, we can feel for these things. Face presentation is sometimes confused with breech presentation. This is a very, very important question which is being often asked in exam, that how will you differentiate breech presentation? Because in breech presentation also, you feel the buttocks which are confused with the cheeks, and you can feel the mouth which is confused with the anal orifice. So it's very common to misdiagnose face presentation as a breech presentation, and to misdiagnose as a breech presentation with a face presentation. So we'll just be learning how we can distinguish between these two. And this is a very, very, very common question which is being asked in examination. So you should listen to it very carefully. So a diagnosis can also be confirmed by ultrasound, which really reveals a deflex or hyperextended neck. So the diagnosis is rarely made before the labor. It is mainly made in the later stages of labor and during the second stage of labor, as I have told you. So the diagnosis can be by abdominal examination followed by vaginal examination, and we can confirm it by sonography. Diagnosis is made by the position of the chin. It is necessary to distinguish between mento-anterior and mento-posterior position. This is again a very important question because there is no mechanism of labor in mento-posterior position unless and until the baby remains in persistent mento-posterior position, the baby cannot be delivered. The chin has to rotate. If this is posteriorly, then the chin has to rotate by 3/8 of a circle, and only when the position becomes mento-anterior, the baby can be delivered by vaginal delivery. If the baby remains in mento-posterior position, the mechanism of labor is not possible there. So how do we diagnose it? In inspection, we will see S-shaped spine. There will be no visible bulging of the flanks. Auscultation, the fetal heart rate is directly audible anteriorly through the chest wall in mento-anterior, and fetal heart rate is not so distinct and is audible on the flank towards the side of the limbs in mento-posterior. In palpation in mento-anterior on lateral grip, the fetal limbs are felt anteriorly, back is on the flank, and the chest is thrown anteriorly against the uterine wall and mistaken for back. In pelvic brim, the head seems big and not engaged. Cephalic prominence is towards the side towards which the back lies, and a groove can be felt between the head and the back. In mento-posterior, the back is felt to the front, and the pelvic rib is almost the same. So this is the mento-anterior position, and this is the mento-posterior position. Normally, in half of the cases, in labor, this mento-posterior position, it turns by 3/8 of a circle, and the position becomes mento-anterior, and the delivery is possible. But sometimes this rotation is not possible. That is, the internal rotation of 3/8 of a circle is not possible, and the chin can remain in persistent mento-posterior position. In that case, we have to take the patient for cesarean section. On vaginal examination, we can palpate for the mouth with hard alveolar ridges. So we can feel for the mouth, and we can, if we insert our finger inside the mouth, we can feel for the alveolar ridges. We can feel for the nose. We can feel for malar eminences. So these are the malar eminences. We can feel for the supraorbital ridges, and we can feel for the mentum. Am I clear? I think I'm making myself clear. So when the face is coming like this, we can feel for all these things, okay? So as I have told you earlier, this condition is often confused with breech presentation. Late in labor, the face becomes edematous because when the face is coming down, just as a caput formation in the vertex presentation, there is edema of the face, and this is known as tumefaction. So it can be misdiagnosed, and it can be misdiagnosed with breech presentation. The cheeks are mistaken for the buttock, the mouth is mistaken for the anus, and the malar processes, they are mistaken for the ischial tuberosity. But in face presentation, the malar eminences and mouth, they form a triangle. You can see in this diagram very clearly. Whereas in breech presentation, the anus and the ischial tuberosity, they are in a line. So this is one of the distinguished feature, and you should remember this. So here a triangle is formed, and in breech presentation, it is a straight line. Finger is sucked in during examination in face presentation. So the fetus has suckling reflex. So if you will insert your finger inside the mouth, the fetus will have the suckling reflex. Whereas in breech presentation, there is no suckling reflex, and your finger will be meconium. It's very interesting, you know, and it's a very common question which is asked in the examination. So, talking about the clinical course, as I have told you earlier, it is adversely affected because the irregular phase ill fits the dilating cervix. This leads to chances of cord prolapse. This leads to delay of labor. There will be weak uterine contraction, absence of molding action of the facial bones, and delayed engagement, late internal rotation, and arrest in mento-posterior position. So I've told you the progress. Persistent mento-posterior position cannot be delivered vaginally. So also the perineal damage is more in phase presentation. This is because the wide biparietal diameter, it is stretching the perineum, and the submento vertical diameter, it is emerging out of the inference. So prognosis, if we talk about maternal prognosis, in mento anterior, the prognosis is good. In persistent mento posterior position, we have obstructed labor, and it can land up in rupture of uterus if the patient is a multi. If we talk about the fetus, there can be cord prolapse, there can be increased time of delivery, there can be cerebral congestion due to poor venous return from the head, and there can be neonatal infection due to bacterial contamination within the vagina. So coming to the next presentation, which is the brow presentation. In brow is an area between the anterior fontanelle to the supraorbital ridges. So these are the supraorbital ridges, and this is the brow, the area of anterior fontanelle. So this area is known as the brow. In brow presentation, all the structures from the orbital ridges to the anterior fontanelle are present, as I have told you. So this from here to here. This area is the brow. The causes of brow presentation, most commonly it is prematurity. There can be multiparity. There can be cephalopelvic disproportion. And in other causes, there can be tumor of the neck, spasm of the neck, and polyhydramnios. So here the denominator is the frontum. So this again, you have to remember all the So talking about brow presentation now. Brow is an area between anterior fontanelle and supraorbital ridges. So as we can see in this diagram, these are the supraorbital ridges, and this is the anterior fontanelle, which is known as bregma. So this area is the brow presentation, and it is, if the baby lies in this position, the presentation is brow. So the causes of brow presentation, they can be, again, they are almost the same as in face presentation. And the most common causes are prematurity and so the most common causes are prematurity, multiparity, cephalopelvic disproportion. And the other causes include tumor of the neck, spasm of the neck, polyhydramnios. So anything which is, it's the same, anything which is hindering the flexion of the head, it can lead to partial extension or the full extension. If there is full extension of the neck, then the presenting part is the face. And if there is partial extension, the presenting part becomes brow. So here the denominator is the frontum, attitude is partial extension, and the engaging diameter is the vertico-mental diameter. And the position can be divided into, since the frontum is the denominator now, so this is used to define the position. So it is left fronto-anterior, left fronto-posterior, right fronto-anterior, and right fronto-posterior. Vaginal delivery is not possible. This is very important point, that in brow presentation, in persistent brow presentation, vaginal delivery is not possible. So either the head becomes flexed and it is a vertex presentation, or the head gets extended and it is a face presentation. Only then the vaginal delivery is possible. In persistent brow, vaginal delivery is not possible. It is usually found early in labor with good contraction. It can flex to vertex or it can extend to face, as I just told you. If it persists in established labor, there is no mechanism of labor or delivery. If undiagnosed, can lead to rupture of uterus in multigravida. So it can, if it is undiagnosed, it can lead to obstructed labor, and in multigravida, there can be rupture of the uterus. The complications which can be associated with brow presentation. So the maternal complications are premature rupture of membrane, cord prolapse, and if undiagnosed can lead to uterine rupture. And fetal complications are related to associated anomalies, operative delivery, and obstructed labor. So how do we diagnose brow presentation? We can see in this diagram, they are showing the brow presentation here. On abdominal examination, head feels broader. Sinciput is at a higher level than occiput, but not so high as in face presentation. Diagnosis with certainty is only on vaginal examination. Anterior fontanelle, forehead, and orbital ridges can be felt. If diagnosed in early labor, the mother is monitored closely, and vaginal examination is repeated every 4 to 6 hours to see the conversion to vertex or face presentation. If diagnosed in active labor, cesarean section is the mode of delivery. Oxytocin augmentation is not recommended. So I hope today we have discussed about face presentation and brow presentation. I hope things are clear, and thank you for your listening.